Welcome, everybody. We'll just wait a couple minutes while everybody files in. Welcome, welcome. Situated. Let's see. People are still coming in. I can start our announcements. Welcome. Good evening, everybody. I'm Rachel Rosen Simpson. I'm the program manager at the Breast Cancer Coalition. I'm so glad that you could all join us this evening. It's a beautiful spring evening, so I especially appreciate you all spending a little time with us this evening to learn more about demystifying your pathology report with Dr. David Hicks. Before we begin this evening's presentation, I have a few brief announcements to share. First off, closed captioning is available at the bottom of your Zoom screen. There's a little CC button if you need. If you missed the link in the Zoom reminder emails for accessing a PDF of Dr. Hicks' slides to follow along with the presentation, I'll drop that link into the chat for anyone who would like it. So I'll do that right now. And here we go. There's that. I will facilitate a Q&A session following the presentation. So as your questions arise, please type them into the chat, and I'll continue to compile them during the presentation. And then I'll share them at the end with Dr. Hicks, and we will answer as many as possible before we try our best to wrap up by 8:30. That's been usually our cutoff time. If you want to watch the presentation again, because it's going to be a really good one, it is being recorded and it'll be added to our webinar library on our website and uploaded to YouTube. So you can share it with anybody else that you think would be really interested. I'll drop that link into the chat as well. So both for the library and for registering for the remainder of the year's educational webinars. And lastly, I have to do my due diligence. It is not too late if you want to participate in the Coalition's largest annual event, the Pink and Teal Challenge, which is the day before Mother's Day on May 10th. I'll be there. If you would like to participate in any capacity, if you want to volunteer, if you want to walk, if you want to run, we'd be delighted to have you. And I hope to see all of your beautiful faces there, as many as can make it. So I'll drop that link into the chat as well. And then I think without further ado, I'm excited to introduce our presenter this evening, Dr. David Hicks. Dr. Hicks currently serves as the Director of Surgical Pathology. Okay, so there's some big words coming up. Of Immunohistochemistry and In Situ Hybridization Laboratories. I got it. As well as the Breast Pathology Subspecialty Service and as a professor at the University of Rochester Medical Center. We are lucky to have such an amazing overachiever in our midst. As a Western New York native, Dr. Hicks earned his medical degree from the U of R and completed his residency in anatomic pathology at the University of Pennsylvania. He has held faculty positions at the Cleveland Clinic, at Roswell Park Cancer Institute, and at the U of R Medical Center. Dr. Hicks has focused much research on molecular genetic profiling of clinical samples from patients with cancer. His recent work has involved a search for new molecular risk factors and pre-analytical variables to better understand the prognosis and guide therapeutic management of breast cancer. So, our esteemed presenter, take it away, Dr. Hicks.
Thank you so much, Rachel, and thank you everybody for joining. It is indeed a pleasure to join you tonight and talk about the topic of your pathology report. And in talking about your pathology report, I would like to introduce you to the most important doctor you'll probably never meet, your pathologist. Your pathologist is a member of the breast cancer treatment team, but he's behind the scenes. He's providing information for your surgeons, your medical oncologists, and your radiation oncologists. and that information is critical to making decisions and determining a patient's likely outcome. So Rachel told you a little bit about my story. I'm a professor at the University of Rochester School of Medicine. I'm a staff physician at Strong Memorial Hospital in surgical pathology, and I actively participate in the care of thousands of patients each year. I do not meet these patients or interact directly with any of them, and most of them don't even know I exist. However, hopefully what you'll come to appreciate by the end of my talk is that my role is critically important to their care and ultimately their outcome. Well, you may be saying, how can this be? I attended Canisius College in Buffalo and then the University of Rochester for medical school. I trained in internal medicine for a year at the University of Pennsylvania, then residency training in anatomic pathology at the University of Pennsylvania, followed by research training. And after all that, I finally got a job as a diagnostic surgical pathologist at an academic medical center. And throughout my career, my clinical and research interests have revolved around breast cancer. And I do actively participate in the diagnosis and treatment planning for these patients. This audience is well aware that breast cancer is the most frequent cancer affecting women in both developed and developing regions of the world. There is a high incidence of breast cancer, and the cancer burden worldwide is quite high. Well, we talk about breast cancer like it's a single disease, and what we come to appreciate is that it's a disease with significant heterogeneity in terms of the clinical presentation, how it looks under the microscope, and even its molecular profile if we were to look at those aspects of the tumor. So a one-size-fits-all approach, which worked well for some patients but not others, is insufficient. So clinicians, in trying to understand this heterogeneity, look at factors to try to stratify patients and predict patients who will have an aggressive course and a poor outcome and separate those from patients who will have a better outcome. And this determines what treatment recommendations they'll make. So they look at lots of different factors: the patient's age, their menopausal status, some aspects of the patient's breast cancer. How big is it? What does it look like under the microscope? Does it invade vessels? Is it been completely removed? What's the lymph node status? What are the biomarkers? We're going to talk about all of those things, so hopefully at the end you'll have a better understanding of that specific information. And it's all used to try to develop a treatment plan, which is tailored to that patient's specific breast cancer. And so your medical oncologists and radiation oncologists and your surgeons, in planning for treatment, basically they're trying to do a risk assessment where they're going to weigh the background level of risk of recurrence. Is this breast cancer going to come back after I've treated it locally? And if I give systemic treatments, those also have a burden and side effects. So it's a risk versus benefit assessment that they make. And like we said, they take patient factors and they take factors from the patient's tumor in the pathology. And these factors are this information from the pathology of the breast cancer is communicated to the clinicians through the pathology report. And so that report contains critical information that your providers are going to use to make treatment decisions. So I thought we could walk through a pathologic assessment of a biopsy or a resected breast cancer case and just show you some of these aspects, what they look like and how these determinations are made. Breast cancer can be detected on self-exam. It can be picked up on a screening mammogram. And for clinically suspicious abnormalities, a tissue sample is obtained from microscopic examination. This is typically done initially with a needle core biopsy, which may be image guided, and then that tissue that's obtained from the biopsy or tissue obtained from the operating room goes to the pathology laboratory for processing and interpretation. Well, biopsies, excisions, or resections are first fixed in formalin, which is chemically fixes the tissue to preserve the morphology, how it looks under the microscope, and also to preserve the proteins and the nucleic acids because they can be assessed for information. That tissue is then embedded in a paraffin wax block, at which point microtomists can cut 4 micron thick sections, put them on a glass slide. That slide can be stained with hematoxin and eosin dyes, and then that stained slide is examined by a pathologist. So we have a suspicious abnormality, we have a biopsy, and the pathologist has multiple roles that they play. The first and probably the most important is they need to establish the diagnosis of malignancy. This was a concerning area that was sampled, and the pathologist needs to say whether a cancer is present or not. If a cancer is present, they then go on to comment about the type of cancer. Is it a ductal cancer, a lobular cancer? What's the grade of the cancer? We can provide information on the anatomic extent, and then we can perform biomarkers, things like ER, PR, and HER2, and that information is used to make increasingly complicated treatment decisions for the patient and trying to tailor the treatment to that patient's cancer biology. And this is all done by a person based on years of training and experience, their assessment under the microscope, and they make that determination that then triggers the treatment plan. So from the patient perspective, they have a number of immediate and pressing questions. What does this diagnosis mean for her future? Will she survive? Will the tumor recur? Does she need any additional treatment beyond surgery? And what are her best treatment options? Well, the pathologist provides many of the answers through their assessment that's used to make these decisions and answer these questions. And those answers are communicated to the other doctors of the treatment team through the pathology report. So just a little more background on breast cancer. The human breast is a glandular tissue, which is made up of a series of arborizing ducts, which end in little secretory units or acini. And this tissue is responsible for providing nutrition for the newborn. The tissue is regulated by hormones and other factors. And if we look at a little bit higher power, the entire mammary duct system is lined by two different cell types, the ducts and the lobules. The ducts are lined by luminal cells, and outside of those, there are supporting myoepithelial cells, and that's all encased in a basement membrane. And the same two cell layers are present in the ducts and in the lobules. Well, breast cancers arise from these glandular cells that make up the human adult female breast tissue. And these tissues are stimulated to grow by estrogen. Normally, estrogen plays a role in preparing the breast for possible lactation. And so estrogen can also play a role in malignant breast cancer cells in stimulating their proliferation. So breast cancer starts within the mammary duct system. And the earliest phase is when the tumor cells are still within that duct space. And they start to fill up and expand the duct. And we see here the cells within this duct space are piling up. They look very different than the normal cells. We see some necrosis in the middle. These these are tumor cells, but it's still contained within the duct system, and this is what pathologists call ductal carcinoma in situ. At some point, through factors that are not well understood, these tumor cells gain the ability to grow through the basement membrane into the surrounding breast stroma. At that point, that breast cancer is invasive, and once it enters the stroma of the breast, that's where it can access blood vessels and spread to other organs. So here is a patient with breast cancer, and we see here on the left, we see ducts which are very well defined. You can see the basement membrane around these spaces. This is ductal carcinoma in situ. And then outside of the basement membrane, we see similar appearing tumor cells that are invading through the stroma. So this is invasive ductal carcinoma. So that would be the diagnosis of a malignancy. Well, you're providing clinicians need a lot more information in addition to whether or not it's malignant. They use staging information, the AJCC TNM staging system, to make decisions about the likelihood of recurrence, and that information is then used to make treatment decisions. So the T in TNM is for tumor, and this is determined by the size of the invasive tumor. TIS is that in situ where the cells are still contained within the basement membrane. And then the greatest diameter of the tumor is measured in centimeters. And it's divided into 4 T stages, T1, T2, T3, and T4, based on how large the tumor is. Another way to think of that is what's the patient's tumor burden. The regional lymph nodes are sampled looking for tumor cells, and the nodal status gives us our N stage. N0 is no positive nodes. N1 is 1 to 3 nodes. N2 is 4 to 9 nodes. N3 is greater than 10 nodes. And so how do we get to a T stage or an N stage? Well, a big part of that is based on the pathologist. The tumor size can be measured on imaging. Your mammographic report, your ultrasound report, your MRI report will all give a tumor size. In the resected specimen, the pathologist, when they come upon a tumor, this is a section of resected breast tissue. Here's the skin up here, so it's a mastectomy. And here's a breast cancer. And so one of the first and most important jobs of the pathologist when they first cut into this tissue to look for the tumor, once they found it, they measure the greatest diameter in centimeters. And that gives us our T stage. Now, what does the T stage mean? Well, if we look at the influence of the T stage on disease-free survival, and we can see here in these Kaplan-Meier curves, the T1 is those patients do fairly well. T2, T3, and T4, the disease-free survival is much worse. So the T stage, it gives you important prognostic information, and that information can be used for treatment planning. How about the end stage? Well, your surgeon typically will recommend sampling an axillary lymph node. Here is a section of a lymph node. We see the capsule of the lymph node. We see lymphocytes, and then we see cells that don't belong there. This is metastatic breast cancer in a lymph node. And sometimes we'll use stains to identify those tumor cells. This is the cytokeratin stain, highlighting these abnormal cells and identifying those as metastatic tumor cells. And again, we can divide the nodal status into N0, N1, N2, and N3 based on how many positive lymph nodes the patient has. And you can see clearly its influence on survival. As the number of positive lymph nodes goes up, the survival goes down. And it turns out that the number of positive lymph nodes is a continuous variable associated with increasingly poor prognosis, the more lymph nodes that are present with metastatic disease. So, axillary surgery or sampling axillary lymph nodes for pathologic examination helps determine the stage and the prognosis. And that information can help define the risk of recurrence. That risk goes up as the number of positive lymph nodes goes up, and can be used in making decisions about chemotherapy. Well, if we look at the lymphatic drainage of the breast, the tumor cells, once they invade into the mammary stroma, can access lymphatic vessels. And much of the breast drains to the lymph node basin in the axilla. There's some drainage on the medial side of the breast to intramammary lymph nodes. And so your surgeon, if he's performing a sentinel lymph node biopsy, will inject some blue dye or a radio tracer into the breast, and that will drain through the lymphatic spaces. And the first nodes to light up with the dye or that radio tracer is referred to as the sentinel lymph nodes. Through a variety of very elegant clinical studies, it's been determined that the sentinel lymph node can be used to assess the state of the axilla. If the sentinel lymph node is negative, there's a very low probability that there will be disease elsewhere in the axilla, so helping to avoid an axillary dissection and potential complications of that. In terms of what the pathologist sees under the microscope, this is a lymph node. This pink layer out here is the capsule of a lymph node. These little small dark cells are lymphocytes, and I think you can see that there's cells in here that don't belong. These larger cells with kind of a purplish hue to their cytoplasm, these are metastatic tumor cells. So this would be a positive axillary lymph node. So when the pathologist looks at the patient's invasive cancer, they want to grade that cancer. They want to evaluate the degree of tubular formation, the degree of nuclear abnormalities, and the degree of mitotic activity. And then that information is used to assign a histologic grade. Grade of 1 is a well-differentiated or low-grade breast cancer. A grade of 3 is a poorly differentiated or high-grade breast cancer, and a grade of 2 is an intermediate. So and you can see from these survival curves, the disease-free survival is quite good for patients with the grade 1 or the well-differentiated breast cancer, and it gets much worse for grade 3 breast cancer. So this provides significant prognostic information to your clinician. So what exactly is the pathologist looking for? Well, he gives a tubular or glandular score. He looks at the degree of glandular or tubular formation that are formed by the tumor cells. If it's greater than 75%, it gets a score of 1. 10 to 75%, a score of 2. Less than 10%, a score of 3. And what does this look like under the microscope? Here's an invasive cancer where the tumor cells are forming these nice, round, glandular structures. We know it's an invasive cancer because these cells are infiltrating through the mammary stroma. They're not contained within the mammary duct system. This is a glandular score of 1. Here, this breast cancer, there's much poorer tubular formation. There is still some tubular formation, but in some areas it's getting solid or trabecular. This would get a glandular score of 2. And then this breast cancer on the far right, we can see that there's no tubular formation at all. There's just sheets of very abnormal appearing cells. This would be a glandular score of 3. The nuclear grade is based on the pathologist's assessment of how abnormal these nuclei are. And basically, the greater the nuclei are in terms of their size, irregular contours, and staining qualities, the more high grade they are. So we look at size, chromatin, and nucleoli to say whether it's a nuclear grade of 1, 2, or 3. And here we see grade 1 nuclei. This is a normal breast duct. This is a neoplastic or cancerous duct. And we see the cells are about the same size. So we have the normal ducts for reference. Here's grade 2 nuclei, where the nuclei are significantly bigger than the normal breast ductal cells, and they're not forming glandular structures. And then nuclear grade 3, the nuclei are several times larger than normal glandular cells. Their chromatin is open. They have prominent nucleoli. These are just very ugly and abnormal looking nuclei. And then a pathologist will do a mitotic count. When cells divide, they undergo mitosis, so the chromosomes form, condense, they duplicate themselves and divide. And you can see that under the microscope. We can see here there are multiple mitotic figures. The mitotic figures say that the cells are proliferating, and the more mitotic figures they are, the more proliferation and the more aggressive the tumor will be. So the ability to assess proliferation of the tumor is important. And so pathologists will do a careful evaluation, and I show you here several examples of mitotic figures. They'll do a mitotic count, and then they'll put the glandular score, the nuclear grade, and the mitotic count together. If the sum is between 3 and 5, it's a low grade or well differentiated. If the sum is 8 or 9, it's high grade or poorly differentiated. And again, this grading that pathologists do has prognostic significance. The pathologist will also look for evidence of vascular invasion within the breast parenchyma in the primary tumor. Basically, breast tumor cells, typically when they invade vascular spaces, they tend to invade lymphatic spaces. And we can see here these very abnormal cells within this space, and there are red blood cells in there. It's next to a small arteriole. This is lymphatic invasion. And what if a breast cancer has lots of lymphatic invasion seen under the microscope, there's a much higher recurrence for early stage breast cancers compared to tumors that do not show lymphatic invasion under the microscope. And here's a couple of examples of lymphovascular invasion. Here we see tumor cells within a defined space, which is a vascular space. Here's some more right next to these little arterioles. And here's lymphatic invasion where this emboli of tumor cells has distended the vascular space, and it can superficially resemble ductal carcinoma in situ, but this is lymphovascular invasion. So there's a couple of major issues that are taken into consideration when treatment planning is done. And the first is local regional treatment. The surgery and or radiation needs to eradicate the tumor at its site, and for local control, you want to prevent the in-breast recurrence. And so the pathologist has a role in that. The surgeon and the patient will determine what type of surgery will be done, whether it be breast conservation and a portion of the breast removed or the entire breast removed. But when this tumor is removed and comes out and goes to the pathology lab, one of the key questions that the surgeon has is, have I completely removed all of the tumorous tissue? So we need to assess the margins. So the surgeon will identify the specific margins on the tissue that they've removed, and the pathologist will report the relationship of the tumor cells to these various margins. And this is helpful if the surgeon determines that the tissue is too close to a specific margin, they can re-excise that specific area. And so I'm going to show you now what that looks like. So if the patient has a partial mastectomy, that tissue comes to the pathology laboratory and it looks like this. The surgeon has oriented it usually with two sutures marking the superior and lateral aspect of the resected tumor tissue. Here we see a localization wire. Now the pathologist, given that orientation, will paint each of the 6 margins, superior, inferior, medial, lateral, anterior, and posterior, different colors. And those colors of ink can be identified under the microscope. And then once that has been painted, the tissue is very carefully and thinly sliced and laid out on a chuck, and a picture is taken. And here we see one of our breast surgeons who'd come up to see the cut breast cancer specimen. And here you can see that the PA who grossed this breast cancer has marked on the diagram where all of the tissue sections came from. Section A1 and A2 came from this slice, and we know that this is posterior, this is anterior, this is inferior, this is superior, this is medial, this is lateral. So with the different color inks and the diagram, and here we see the tissue being laid out in the cassettes corresponding to the diagram, I can, under the microscope, say, here's the tumor tissue, here's the green ink, which is typically the inferior margin, and I can make a measurement and report to the surgeon how far the cancer was from that specific margin. Now here is another resected breast cancer. We see black ink here along the surface, which is typically the posterior aspect of the partial mastectomy. And I think you can clearly see that tumor cells go all the way up and touch the ink. So the surgeons will talk about no tumor on ink. Well, this would be a positive margin. And here's a very subtle. Blue is usually anterior. This is a lobular cancer, which grows as these small little cords of cells, and they trickle all the way up and touch the ink. So this is also a positive margin. So this is important, and this information is used by the radiation oncologist. It's used by the surgeon to decide if additional surgery is needed. And here's an example of ductal carcinoma in situ down here at the bottom. And one of the challenges that we run into is that ink, if it's not carefully applied, can seep into cracks in the tissue, and it can be quite complicated. So this whole process of orienting, inking the specimen, and then examining it under the microscope provides, to the best of our ability, the status of the margins and whether the tumor has been completely removed by the surgeon. Now, the other aspect of breast cancer treatment is, after the local regional aspect, is what about tumor cells that may have spread beyond the confines of the breast prior to the surgery and have gone to other organs? And then this is where systemic treatment comes in, treatment that goes through the bloodstream and can reach cells that may have gotten beyond the confines of the breast. And the type of systemic treatments that are used include anti-estrogen or hormonal therapies, which we'll get into, chemotherapy, and then targeted or biologic therapies, things like Herceptin, which targets HER2. So the decisions about systemic therapy are complicated. They're based on an assessment of the tumor biology, the tumor characteristics, the risk assessment, and these biomarkers. So it is recommended that ER, PR, and HER2 be determined on all invasive breast cancers. These are important because these represent pathways that drive disease progression. These are molecular drivers of the disease. And the ER pathway and the HER2 pathway, because they're driving the disease, they can be targeted for treatment, and this is quite effective. Um, and so this represents sort of a historic progression of our understanding from breast cancer to breast cancer as a single disease, to breast cancer which can be subdivided based on the hormonal status and the HER2 status, and then increasingly complex using molecular profiling. Um, we can identify a variety of different molecular subsets of disease. These things all correlate with one another, and so this is where we're at historically in making decisions about treatment. So, in terms of the biomarkers, going back to our breast cancer has significant diversity. Um, we use known breast cancer biomarkers, things like ER and HER2, to try to identify it, assess the biology and molecular drivers of disease progression for that breast cancer, it, because we can target these for treatment. So, what does this look like? Well, I think about ER positive breast cancer as an ER driven breast cancer. There's a lot of information on this slide. ER is present in 70–80% of breast cancer, so it's a significant percentage of the breast cancer population. And ER binds with estrogen, is translocated to the nucleus of the tumor cells. It undergoes dimerization and phosphorylation and binds to the DNA and promotes growth. So this is driving tumor growth and disease progression. That's the bad news. The good news is that we have multiple strategies that we can use to target and disrupt this molecular driver, things like tamoxifen, which antagonizes this process, aromatase inhibitors, which blocks the local production, and more recently, CDK4/6 inhibitors and estrogen receptor degraders. The number of different treatment options for ER positive breast cancer just continues to expand. So, how does the pathologist assess for ER in a breast cancer? Well, we see here on the left normal breast glands, breast tumor cells, and we use antibodies which can identify proteins like the estrogen receptor. We bind that antibody to the protein in the tissue section, and then we can use a second antibody which has an enzyme which catalyzes the precipitation of a dye to detect the presence of the estrogen receptor. So we see here the patient's normal glandular cells are ER positive. We see good brown dye telling us that ER is present in the nuclei of these normal breast epithelial cells, and it's also present in the nuclei of the patient's breast tumor cells. So this patient's breast cancer is ER positive. Now, I think you can imagine that the quality assurance and quality control around this testing has to be enormous because the results are directly linked to making a treatment decision for that particular patient. So I think you can also imagine that there's a whole range of levels of ER expression from tumors which have a low percentage of tumor cell nuclei with weak to moderate staining. This would be a low ER positive breast cancer. That information is going to trigger different thoughts about treatment compared to breast cancer with very high levels of ER expression, where there's strong ER signal virtually in every tumor cell. These breast cancers with this strong ER expression and high levels of ER detected These are the patients that are the most likely to benefit from endocrine therapy. And so, given that there's this whole range, pathologists have a complicated scoring system where they assess the proportion of tumor cells that are positive and then the average intensity, and that is all added up to give you an all-red score. But the gist of it is they're trying to capture the range of levels of expression because that information could be useful to their providers. So the other biomarker is HER2. HER2 was discovered in the 1980s by Dr. Dennis Slayman, a breast medical oncologist out in California, and where he was able to show in patients with metastatic breast cancer, a subset of the breast cancers, around 20%, had amplification of the HER2 gene. There were multiple copies of the gene in the tumor cell, and this amplification led to overexpression of the protein in those tumor cells. And patients with this alteration, gene amplification and protein overexpression, had a much worse survival, short and median survival in the metastatic phase, in the early breast cancer phase. So it was clearly playing a role in making these breast cancers more aggressive. And Dr. Slayman correctly hypothesized that this alteration, amplification, and overexpression was playing a role in making these breast cancers more aggressive. So it was an ideal target for therapy. And so monoclonal antibody therapy was born. The drug Herceptin was developed to target this HER2 overexpression and has been shown to be remarkably effective. So we now know a lot more about HER2 from those early days. It's a gene that's located on chromosome 17, and this gene plays a role in normal growth and development of breast epithelial cells and a variety of different epithelial tissues. That gene gives rise to 185 kilodalton transmembrane growth factor receptor that again plays a role in normal growth and development. So in a normal breast epithelial cell and in a breast cancer tumor cell that's HER2 negative, there's about 20,000 copies of the receptor at the membrane of the tumor cell. When the gene is altered and amplified, there's multiple copies of the gene on chromosome 17. This drives the expression of the gene, leading to this gross overexpression of the receptor at the membrane of the tumor cell. This increases the likelihood of receptor activation. And I'll show you what that looks like. Here's the normal HER2 function. It's a growth factor receptor present in the membrane of the cells, and it regulates growth and development, has a role in angiogenesis, cell proliferation, and apoptosis. In patients with the HER2 alteration, we now have huge numbers. The number of copies of the receptor goes into the millions. And this increases the likelihood of this receptor activating and signaling and is associated with stimulation of angiogenesis, cell proliferation, invasion. So it plays a direct role in making the tumor cells more aggressive. And a different way of visualizing this is here's the normal breast epithelial cell or a HER2 negative breast cancer cell. We see HER2 at the membrane of the tumor cell. But these HER2 positive breast cancers with increased expression of the protein, this is driving signals that cause these cells to proliferate, leading to an aggressive clinical course for this patient. So how do we measure it? Well, we use immunohistochemistry, and we score the HER2 status based on the percentage of cells with membrane staining and the intensity of the membrane staining. And we divided it into 4 categories. An absence of membrane staining or faint, weak, partial membrane staining. This is considered a negative result. And if we were to perform in situ hybridization, the vast majority of these breast cancers are going to be non-amplified. These patients are HER2 negative, and these patients are not candidates for therapy that targets HER2. At the other extreme, you can see here a breast cancer with this strong circumferential membrane staining, complete surrounding each tumor cell, so-called chicken wire pattern of staining. The vast majority of breast cancers with this staining pattern are HER2 gene amplified. These patients are candidates for HER2 targeted therapy using these monoclonal antibodies. Now, this is a spectrum, so in the middle, there's a intermediate category where there's weak to partial membrane staining, some complete but not uniform. These are scored as equivocal. These this is not sufficient for making a treatment decision. So these patients undergo in situ hybridization to determine if the breast cancer is, if it's not amplified, it's considered HER2 negative. If it is amplified, it's considered HER2 positive. So the assessment for this monoclonal antibody therapy is HER2 positive versus negative. Again, this testing is responsible for determining how a patient will be treated. So let me show you some examples. Here are some breast cancers with this strong circumferential membrane staining uniform throughout the tumor, the so-called chicken wire pattern of staining. A few years ago, I was giving a talk in New York City, and I was showing a slide similar to this and talking about the chicken wire pattern of staining. And somebody in the front row raised their hand and said, "Excuse me, what is chicken wire?" And so I grew up on a farm out here in Western New York, so I thought everybody knew what chicken wire was. So, but that's exactly what it looks like. These breast cancers are HER2 positive. They do not need in situ hybridization. These patients will have a more aggressive clinical course and are candidates for HER2 targeted therapy. Now, here's a couple of breast tumors where it's not so clear. I don't see that nice circumferential membrane staining. There's some, but it's not uniform and it's not that strong, distinct staining quality. These are the equivocal patients who need to undergo FISH testing to determine the HER2 status. Well, what is FISH testing? Well, we said the gene was located on the chromosome, and that chromosome is in the nucleus of the tumor cell. So we can use nucleic acid probes with a sequence of nucleic acids which are complementary to the HER2 gene. And we can attach to that probe fluorophore, which under fluorescent light will be bright red. And we can hybridize this probe to sections of the tumor and then go in and actually count the number of copies of the HER2 gene to determine the gene status. And let me show you a couple of examples. Here's an example of in situ hybridization. The red are the HER2 genes. The green are a reference probe for chromosome 17. And we see here that, and then the nuclei are counterstained with a blue dye, DAPI, which allows us to see them under fluorescent light. And we can see here that the vast majority of the tumor cells have 2 copies of the red signal, 2 copies of the green signal. So this is a non-amplified breast cancer. And compare that to this one, where the red signals, there's so many of them that they're forming small clusters. This is a highly amplified breast cancer. This patient is a candidate. And again, this receptor sets on the membrane of the tumor cell. When it's overexpressed, it gets activated and signals to drive the tumor to grow. And the drug trastuzumab can bind to an extracellular portion of this receptor and block that signaling. And it becomes a very effective means to treat that patient's breast cancer. So I've taken you through a lot. I've shown you the diversity and the heterogeneity of breast cancer. I've shown you biomarkers, how they're determined, and some of what they mean. And hopefully I've left with you a sense that pathology is important in determining your treatment. So going forward, we strive for a better understanding of the molecular differences that can lead to rational, objective criterion that will tell us how patients will do and guide the most appropriate treatment for each individual patient. So I hope you never need a biopsy, but if you do, remember to ask the doctor who your pathologist will be. They may be the most important doctor that you will never meet. And with that, I want to thank you for your kind attention. And I turn it back over to Rachel, who will, if she's got questions, we'll be happy to try to answer
Oh,
those.
ew. Thank you so much, Dr. Hicks. That was a throwback. I don't know if anybody else found themselves in like first year bio remembering things about mitosis and nuclei and all sorts of good stuff. Uh, but anyway, I learned so much. I do have a few questions, and there were some hands raised, but if people could drop their questions into the chat, I'll start with the ones that have already come in. And then I will get to anything else that comes in as we go. The first question that came in asked, can you speak more to HER2 low and what that means? Which you did start to touch on that. Would that be found in the pathology report? Apparently, and this is, yeah, difficulty for everybody, people are seeing more ads for treatment for HER2 low breast cancer. And if HER2 equivocal by IHC but negative FISH, does that mean that I am HER2 negative for sure, or potentially HER2 low or ultra low? All of these terms. That was the lot.
Well, those are great questions, Rachel. And the HER2 world was fairly straightforward and binary for a long time until we had this concept of HER2 low. And we said HER2 was either negative or positive. And that was to make treatment decisions. You had to be positive to get monoclonal antibody therapy. And if you weren't positive, you weren't a candidate. Well, I showed you that there's a whole range of levels of expression. And so the things that were negative still had HER2 protein, but it wasn't that strong circumferential staining. It wasn't driving the disease. Well, the pharmaceutical industry, who continued to make fantastic innovations, said, well, what if we take an antibody which will attach to HER2 and we link it with a chemotherapy that is stable in the circulation attached to the antibody. And when it gets to the tumor and binds to the HER2 at the membrane of the tumor cell, that chemotherapeutic agent can be released and kill that tumor cell and the surrounding tumor cells. So this was tested initially in HER2 positive patients who had failed conventional treatment, and there was like a 60% response rate, just dramatic. And so the next question was, well, if it works so good for HER2 positives, can it be effective for these patients who have lower levels of expression that aren't HER2 positive, that we're calling negative traditionally, but still have HER2 protein? And so the Destiny Breast 04 and more recently 06 tested out that hypothesis. And so breast cancers that were IHC 1 plus or IHC 2 plus not amplified had remarkable responses to these antibody drug conjugates. So these we're starting to call HER2 low, and they're candidates. And more recently, they said, well, what about those that are less than 1 plus but have just only some little bit of staining? We're calling those ultra lows. Those also respond. So the pathology community is trying to keep up with this, and we've had a series of discussions with the medical oncologists. We report the percentage of cells that are showing membrane staining, the pattern of membrane staining, and the intensity of the staining. So the medical oncologists can look at our report and know immediately if this is ultra low, low, or HER2 positive. Adding these words to the pathology report in some for some people, they feel it's premature because these aren't biologic entities. These were defined by a clinical trial that said you were eligible if you showed this. So I think that if there's a question, the clinician should call the pathologist, and you know, you could a patient can call pathologists too. I not infrequently will get calls from patients, and I was recently asked to give a talk at the University of Miami, and they had started having sessions with patients where patients, as part of their multidisciplinary team, if they wanted to spend time with a pathologist, they could Zoom with a pathologist and go over their pathology report, go over their slides, so that and whether that's something that whether there'd be interest here or not, I don't know. That would have to have full buy-in from the clinicians in order for that to work. But um, I think there's lots of questions that patients have, and hopefully I've given you guys some tools and some ideas so that you can read the pathology report and understand it a little better.
Yeah, definitely. There's a lot to digest. And I think I speak for probably a lot of people that they would love to meet with you and ask you questions directly. I hope that is a thing in the future. Yeah, put in
Well, you guys can advocate your providers for that. How about that?
that sounds good. Okay, I have a few more questions here. A whole bunch of questions have been coming in about Ki-67. What is it? How is it used in treatment decisions? Can you explain the Ki-67 proliferation rate? Um,
Sure.
and then whether it's a permanent characteristic of the cancer through the life of treatment, or is it only meaningful at the initial evaluation for a solid tumor? So,
It's fairly stable throughout the patient's course. I showed you mitotic figures, and that was one measure of proliferation. The more mitotic figures, the more proliferative the tumor is. The more proliferative the tumor is, the more aggressive it's going to be, but the more likely it is to benefit from chemotherapy. So there are other ways to measure proliferation. I know that there's a question coming up on oncotype. The oncotype measures several proliferation genes. Ki67 is a protein that's expressed in the cell cycle of cells that are actively dividing. So Ki67 positive tumor cells are cells that are proliferating or dividing. So, and again, there's a whole range from less than a percent, which would be a very low proliferative tumor, which would be likely be very indolent and not likely to benefit from endocrine or chemotherapy, to highly proliferative tumors where 50, 60, 70% of the cancer cells are Ki67 positive. This is most likely seen in your triple negatives or your HER2 positives, those highly proliferative tumors. They're going to be aggressive. They're going to respond to treatment. Uh, Eyeballing and assigning a percentage of cells is not straightforward, and there's some variability. But I think it's still useful because you can put the Ki into buckets. Less than 10% we can identify pretty reproducibly. Those low proliferative tumors are usually low grade. They're usually PR positive. They're usually HER2 negative. Highly proliferative, greater than 30-40%, that's usually pretty reproducible. Those breast cancers are going to be more aggressive. They're usually triple negative or HER2 positive. Then in the middle, between 10 and 30%, it's not as clear. That's kind of a gray zone where you need more information. But I think more and more the clinicians are using Ki as just another data point to make decisions about how aggressive the tumor is going to be and what the best treatment is. And Ki67 is a gene that's measured in the oncotype, so it's a good proliferation marker.
Well, that leads us to the next question, which somebody did ask. Can you please explain Oncotype DX?
Okay, Oncotype DX is a multi-gene assay where the paraffin tumor tissue gets ground up and all of the gene transcripts, the mRNAs, which tell you which genes are turned on, are extracted and measured. And the way they developed this was they took a whole bunch of breast cancer patients. They developed RT-PCR tests for a whole bunch of different gene transcripts. And then they measured them, and then they looked to see, they looked for correlations with prognosis. And so they found all the univariate correlations with genes that predicted for a good outcome or a bad outcome. And then they used some fairly sophisticated informatics and an algorithm which settled on 16 genes, which in combination with weighting factors could give the patient a low recurrence score associated with a low risk for recurrence, an intermediate, or a high recurrence score, a high likelihood of recurrence. The low recurrence score patients had a 10-year recurrence of, I believe, about 6%. The high recurrence score patients had a 10-year recurrence of 30 or 40%. So, and it only works for ER positive breast cancers. And they subsequently have shown that the chemotherapy benefit was just seen in those ER positive breast cancers that had a high recurrence score and was not in those ER positive breast cancers that had a low recurrence score. And this was true if they were node negative or even if they had 1 to 3 nodes positive. So it's another piece of information that ideally is going to be used in and interpreted in the context of the grade of the tumor, the ERPR status, the tumor stage, and the other information. But it gives you a risk of recurrence, a number that the medical oncologist can use, saying, no, this patient will not benefit from chemotherapy and they will have the burden of the side effects, or this patient is the most likely to gain benefit.
So fascinating. Um, for you were talking about Herceptin and you referred to it as a biologic, or I think it's in that same class maybe as immunotherapies, or maybe that's different. But somebody did ask, how does Keytruda work and how is that different than Herceptin?
Well, that's a great question. Herceptin is targeting, it's an antibody, and the antibody was developed in a mouse. And if we gave human beings mouse antibodies, they'd mount an immune response, and so it wouldn't work. So again, the pharmaceutical industry is just amazing. They figured out how to take the antigen recognition part from the mouse antibody, and humanize it, put it on a human IgG backbone, so that the immune system would not mount an immune response. So here are your breast cancer cells that have lots of copies of HER2, and the antibody is binding and blocking that. And that's shutting down the driver. Those HER2 positive breast tumor cells are addicted to that HER2 signaling. That's what's driving. So blocking it shuts it down. Immunotherapy is also antibodies, but it's an antibody against programmed cell death ligand. The breast cancers have the ability to evade the immune system. There's immune surveillance, and if you developed a cancer, you would want your immune system to detect it and attack it. Well, and that probably happens to some degree in normal people, and we don't even know about it. But once a cancer is established, one of the ways that the tumors evade the immune system is through these immune checkpoints that are there to protect normal cells against the immune system. Well, the cancer cells exploit that and mask the ability of the immune system to detect them. And one of the main ones is this PDL1. And Keytruda binds that checkpoint, blocks it, releasing the immune system to mount an immune response against the cancer. And it has proven to be remarkably effective. Now, one of the downsides is that that patient's immune system can then begin to attack normal cells. And some patients treated with Keytruda can get autoimmune thyroiditis or other autoimmune problems. But that's also a biologic. So we've gained so much in our knowledge. First of all, understanding the biologic drivers of the disease, and then coming up with creative ways to target those uh, to effectively treat the patient's breast cancer.
And, any cancer evades the
Yeah,
immune system, correct? So,
Keytruda plays a role in lung and melanoma and breast and GYN. I mean, the list of cancers that Keytruda, and what that tells us is that the immune surveillance and um, the ability to mount an immune response against a tumor is effective, and it's not limited to a certain cancer type. It's a agnostic ability.
it seems like it has revolutionized treatment, and I hope we continue to go in that direction. There are a few other questions about like specific things on pathology reports. Can you explain the Nottingham grade?
Sure. Well, the Nottingham grade, the Nottingham, England, is where there were a lot of pathologists who did these early studies, and that's the tumor grade. The Nottingham grade is when we score the glandular formation, score the nuclei, and score the mitotic figures and add them up and get a well differentiated, moderate, or poorly different. That's the Nottingham grade. And it's interesting. If you take a grade 1 tumor and a grade 3 tumor and you look at the molecular profiles, they're completely different. That at least at a biologic level, they look like different malignancies. And the only thing they have in common is they share that they arise in one anatomic location, the breast. But breast cancers, there really are multiple different types, and I think the more we learn about them, the more we've appreciated that you have to understand the specific cancer type and what its drivers are to develop effective strategies to treat them.
And much more targeted treatments for a particular person, for a particular cancer. Yeah, the more I learn, it's fascinating, but it's very individualized, it seems. Another participant had a question about what particular terminology means in a report. That
Oh, okay.
estrogen receptor was positive, all red, score 4, and tumor nuclear grade was intermediate to high nuclear grade.
The Allred score, uh, we talked a lot about how these things are not binary black and white, how there's a spectrum, and you can go from very weakly ER positive to strongly ER positive. The Allred score is a combination of the proportion of cells that are staining and the intensity of staining, going from 0 to 8. 8 is greater than 60% with strong staining. Now, and we score positive and negative is not enough information, so we have to give the semi-quantitative assessment. Now, what was the other one was intermediate to high grade? Well, um, I, the chief of pathology, when I trained many years ago, if you bring something to her and say, this is intermediate to high grade, she would say, don't be a mugwump. And I'd say, what's a mugwump? She'd say, it's a bird that says with his mug on one side and his wump on the other. Um, it's intermediate to high grade means it's kind of in the middle and they're not sure. So just to make
Oh,
sure, we're going to put it all in there. And they really should try to make a determination. And that's why we have very specific criterion. But um, I, to this day, tell my residents not to be a mugwump if they bring something to me that says intermediate to high grade.
okay. I will totally remember that. Oh goodness. I didn't think I would be laughing that much during this, but I think this is important. The levity is important to deal with stuff that's really intense. One question that was asked, this is something that actually Dr. Hicks and I were talking about in our little session before we let everybody into the room, but I asked, are slides or samples of cancer and biopsies kept for any length of time? And I also asked, if so, where are they kept?
Well, there's an archive. New York State requires that the slides and the blocks be kept for 20 years. And if a patient recurs, it's not uncommon that we'll want to go back to their previous pathology and compare it. If a patient develops metastatic disease in another body site, we want to compare it to the primary. So it's valuable to have them around. But yes, and there there are these archive rooms um, that are temperature controlled and humidity controlled because you want to preserve the tissue. And but if you think about it, we do over 100,000 cases at Strong Memorial each year, which generates probably several million slides times going back to 1925. So there's just oodles of glass slides everywhere.
Oodles. So one other question is, are the U of R's samples kept separately from other, like Rochester Regional Health, for example, or do they all get housed together?
No, they're kept separately. Each institution is responsible for the storage and retaining the archives. Now, there's occasion when a patient who had been initially seen at Rochester Regional will come to Strong and will request the slides or will request the blocks. And so it's fairly easy and straightforward to gain access to material um, from outside. And then if somebody at another institution is unsure and wants a second opinion, they may send a case here.
Mm.
Could you give us your opinion? This is what we're thinking. And so, or we may send a case out if we're not sure what the best, most appropriate answer is, because we want to get the best answer, the the right answer for the right patient at the right time.
That's really great and very interesting. Um, what, if any, is the significance of neuroendocrine features of a breast cancer tumor?
Well, neuroendocrine features, it turns out it has no significance in terms of prognosis. It's a type of differentiation that you can see typically in ER positive breast cancers. It gets more into the nuance of pathology, but in terms of what it means for the patient, um, it has no prognostic significance.
Okay. Going back to that Ki-67 or Oncotype, the DX, um, there was somebody who wasn't offered those things as an option because the oncologist told them that it wouldn't make a difference whether they needed chemo or not. But is it something that people could request if they wanted to know?
I I think absolutely there should be a discussion with the patient's provider. I will say that a 1 centimeter tumor that's grade 1, that's strongly ERPR positive, that's HER2 negative, that has a low KI below 5%. I don't think that's going to add anything. That's going to be an indolent breast cancer. The oncotype is going to be low risk. And if the oncotype came back anything other than low risk, I would question the oncotype. I think you'd have to resolve that. The patient with a large locally advanced breast cancer that's grade 3, maybe weakly ER positive, highly proliferative, that's going to come back with a high recurrence score. But that leaves a lot of patients in the middle, which bigger tumors, maybe intermediate grade, maybe lower levels of ER expression or higher Ki-67. It's those patients where the pathology data is not clear, where the oncotype can be extremely valuable. So the oncotype needs to be interpreted in the context of the rest of the pathology to to use it appropriately.
For anyone who's interested, you used that term indolent, and I actually looked up the medical definition of that last week, and it said lazy or slow growing, which I thought lazy was an interesting term to use when describing a cancer, but I guess everybody hopes that their cancer is lazy.
Yeah.
But indolent sounds much fancier. Um, Another participant asked, can patients have access to the pictures of their cancer tissues and samples if they want?
I I don't see why not. I would request that through your surgeon probably or your medical oncologist. Occasionally, I had one lady who wanted to see her tumor cells so that she could visualize them and make peace with them, and I showed them to her, and that meant a lot to her. So
Hmm.
I think that um, if we were doing these pathologist patient sessions, that would be another way to do that. But I think if a patient was interested in that, they should discuss that with their surgeon or medical oncologist.
Um, Another person asked whether, pathology reports at this particular institution take 7 to 10 days. Is that due to a specific process that takes place in the lab, or just because all of what you have talked about today takes time?
It takes time. I mean, the tissue comes in from all sites and at all hours, and it we accept tissue from that needs to be transported by a courier. And when it gets here, it needs to undergo that gross assessment and dissection, and then that tissue needs to fix overnight, and then get embedded in that paraffin wax, and then the histotechs need to cut the sections and stain them, and then the pathologist looks at them. If the case is straightforward, at that point it can usually be signed out. Oftentimes they want additional opinions, they may want additional studies. Uh, Again, trying to make sure that they get the best possible answer. And 7 to 10 days is that's the average. Some quicker, some longer. But I think that again, my old chief of pathology had a great influence on me. She always, when people complained about the turnaround time, she said, you can have the answer fast or you can have the answer correct. And so sometimes getting the right answer takes time.
Yeah, it's a good answer on her part. Um, Another participant asked if the PR negative aspect of the diagnosis Is it still treatable as long as one is ER positive, so estrogen positive?
That's correct. PR is interesting. PR is regulated by ER. So in order to be PR positive, you have to be ER positive. Um, and so originally, PR was measured um, as a surrogate for ER because really hormonal treatment targets ER. And but one of the things we began to appreciate is that a small percentage of ER positive breast cancers are PR negative. It's about 10%. And those patients are more aggressive. They usually have a higher oncotype recurrence score. And um, if you did gene expression profiling, they come out as a luminal B subtype of breast cancer. So the PR is not very helpful in deciding if a patient is a candidate for endocrine treatment, but it is prognostic. So it's another bit of information. Imagine the medical oncologist taking all these little bits of information that are prognostic and trying to put it all together. And a lot of what we know about is based on populations. So they say, well, your particular breast cancer, if we had 100 patients similar to you, 90% would do well and 10% would do bad. And so odds are pretty good, but it still doesn't tell you which side of that you're on. And so the goal of research has been to try to refine and better understand so you could get a more specific reading for individual patients. We're not there yet. The oncotype gets us closer, but it's still a population uh, statistical type of information.
Okay, that's very helpful. Okay, I think there's only a couple questions left for anybody who's willing to stick it out. Um, Curious whether you're in the same building as the medical oncologists and do you work closely with them in order to devise these treatment plans? Like, how much back and forth is there with pathology? Or is it sort of you make your report and then they take it from there?
It's a great question. I will tell you, 20 years ago when I came here, we were all in one place. And they were in the cancer center here on campus. And we all got together in a big room in the cancer center once a week. And we had regular face-to-face meetings. They moved out to Red Creek or Pluto,
Mhm.
and the imaging is now out at Red Creek, and we have surgeons in Canandaigua, and so it's become more and more multi-site and regional, and and it became increasingly difficult. And then the pandemic hit, and then everybody does everything now on Zoom. So just like we're talking now, uh, I will talk to medical oncologists or surgeons um, frequently over Zoom. Every Monday morning is the tumor board where patients, where there's a specific question, will get put on the tumor board and they'll go over the imaging, the clinical, the pathology, and then there'll be a robust discussion of what the treatment options are, and that's usually very interesting and very helpful. And pathology is a part of that, and so I miss the actual physical interactions with the clinicians because we're so remote. But that's how just how medicine has become,
Yeah.
and so but and we never see the patients. Um, I'm a name on a report, but my contribution to that patient's care is key.
Yeah, people are talking about how important the tumor board is. And it sounds like it's great to kick off the week with that every week on a Monday morning. Um, I think there's one last question about, I wanted to wrap it up with this one. Do you anticipate, I guess this is your personal opinion, any major breakthroughs with regard to treatment or even a cure for the question was about breast cancer in particular, and how women are getting diagnosed at increasingly young ages, and many people have no family history and also test negative for genetic mutations. So there is increasing concern about um, the proliferation in younger women of these diagnoses.
Yeah, that's a fabulous question, and I don't have a good sense of what's going on there. I think in terms of major breakthroughs, I think the development of antibody drug conjugates is hard to overstate how important that has been. And a lot of times with new therapeutics that are tested in the advanced cancer stage, that certainly was the case with trastuzumab or Herceptin. It was initially tested in metastatic breast cancer. It was dramatic improvement. Um, it was then moved into the early phase adjuvant, shown to be 50% reduction in recurrence, tested in the neoadjuvant phase, increase in pathologic complete response. And so we're seeing the antibody drug conjugate sort of move from the advanced HER2 positive metastatic breast cancer to HER2 low. And now we're seeing it move into the earlier phases. And I think it'll be incredible to see how those new reagents work. And as they've gotten better, the chemistry, the ability to attach think about it, chemotherapeutic to an antibody and have that linker stable in the serum. And when it gets into the microenvironment of the tumor, to have it be released and then membrane permeable and diffuse and kill tumor cells, they call it the bystander effect. And um, I think that we have a few antibody drug conjugates. I predict that in the near future, we're going to see a whole raft of new ones using different antibody targets, different payloads, and it's going to be remarkable. Going to keep your local pathologist busy trying to stay up with all that and figure out what diagnostic tests are going to be needed to determine eligibility.
Well, I kind of hope you're right, for everybody's sake, as it seems like they have, yeah, definitely changed the trajectory of so many people's, yeah, progression and quality of life. So I think we are at time. And this was so fascinating and illuminating. Everybody is going to drop their gratitude into that chat about how grateful they are that you spent time with us. Um, I want to remind everybody there's going to be a survey that pops up afterwards. Please tell us your feedback about what you want us to have these webinars about, because these are the ideas that we really listen. Um, so thank you so much for spending some time with us, Dr. Hicks. Thanks to all of you for spending a couple hours with us on a Wednesday evening. And we'll be together again next month. And yeah, I hope that sometime we get to meet in person, Dr. Hicks, because it's been a pleasure.
Well, God bless everyone. This has been my pleasure, and I'm glad if it was helpful.
Definitely. I learned
All
a lot.
right.
All right. Take care, everybody. Have a great evening. Enjoy the spring.
Bye
We'll
bye
see
bye.
each other in the wild.